Hello, everyone. My name is Hannah, and I would like to thank you for joining today's webinar, eMOLST, Digital Transformation of New York MOLST and End-of-Life Care Transition Program, presented by Dr. Pat Fomba and Katie Orem. Before getting started today, I would just like to note that we'll address your questions at the end of the webinar, so if you could just please type them into the chat box, that would be great. All right, now I would like to welcome today's first presenter, Dr. Pat Fomba. Thank you.
Thank you, Hannah, and I thank everyone for joining us today as we talk about eMOLST and what we have done in terms of digital transformation of New York MOLST and end-of-life care transition program. Our goals today are to examine why there are failures in following the paper MOLST orders and review recommendations for improvement, including eMOLST. We'll define eMOLST as a tool that assists both patients and clinicians with end-of-life decisions, and discuss how eMOLST improves quality and patient safety, ensures accessibility, and achieves the triple aim. After we provide background, we will demonstrate the eMOLST application. With me is Katie Orem, the eMOLST administrator. I want to first talk about advanced care planning and remind all of us on the call that this is a communication process that we should be starting earlier along the course when people are healthy and independent, and not when they are at brink of death in the ICU, where typically they lack the ability to make decisions. We want to move it upstream, early identify those that are appropriate and are safe for MOLST or for any POLST paradigm program. It wouldn't surprise you if they die in the next year, not waiting till the end. But advanced care planning really begins when people are healthy and independent as early as 18 years of age, and the focus should be on a healthcare proxy or a durable power of attorney for healthcare, along with conversation with the patient's family as they define their family, caregivers, etc. If you begin this process at 18, your values, beliefs, the goals for your care, and certainly what matters most changes as you age, and certainly what you want at 18 is not what you want at 85. That's important as we begin to talk about eMOLST, because we are not really talking about storing our advanced directives, but rather our medical orders. This is the definition of advanced care planning from the Institute of Medicine report, Dying in America. So it is that whole process of discussing end-of-life care, clarifying values and beliefs, and really completing documents, either advanced directives or medical orders. And it can start at any time, visited periodically, but it does need to become more focused as health status changes, resulting in completion of a POLST paradigm form. Ideally, it should be with the healthcare agent and the primary clinician, along with other members of the team. It should be recorded, updated as needed, as goals for care can change over time, and that allows for flexible decision-making in the context of the person's current medical situation. At the completion of the process, the communication process for all adults, typically advanced directives ought to be done. As I said earlier, the focus is on a healthcare proxy. Your state-specific form may be a durable power of attorney for healthcare. We do not store these documents in our eMOLST application. Rather, that we're focused on storing MOLST forms and copies of the conversation, as we'll illustrate later today. We've built our program on the POLST paradigm and have integrated it with New York State public health law. The result of the conversation, which is a shared decision-making conversation that is well-informed, is a set of medical orders, and it represents a common community forum. In New York, we define, similar to other endorsed programs, people with serious illness are appropriate for a medical order. People who want to avoid and or receive any or all life-sustaining treatment, those are typically people of advanced age, people who would reside in a long-term care facility, or increasingly receiving services at home and aging in place when indeed they might qualify for a long-term care facility. Or the surprise question, persons might die in the next year. We know in the paper world we have seen failures in following the paper MOLST. Clinicians, patients, families are sometimes unaware of their obligations to follow MOLST and the implications of failure to follow it. This is about person-centered care and not healthcare agent or surrogate-centered care. Completion of medical orders represents clear and convincing evidence of what the person wants. It's also sometimes failure to recognize that advanced care planning is a process as defined in the IOM report. Emphasis needs to be on communication. Forms are the end. It is not just a checkbox and a listing on a form. Increasingly, people are paying attention to the discussion, but it's important that the forms are done, and it's important to avoid incorrectly completed forms. In the case of medical orders, to avoid incompatible medical orders like CPR and do not intubate. Oftentimes, early discussions are avoided, or the focus is on interventions rather than personal values, beliefs, and goals. And in the words of Atul Gawande, what matters most. And too often, the wrong healthcare agent is chosen. We have seen in our state people misunderstanding the differences between advanced directives and medical orders, and some thinking that a set of medical orders is an advanced directive on steroids, rather than really representing what people want right here, right now, when they're seriously ill based on current health status. We've also seen failure to assess and document capacity and other legal requirements. If it's not documented, it hasn't happened. And even in the settings where we've done it right and there have been thoughtful discussions, proper documentation, we have seen failures in accessibility to the paper MOLST. Recommendations that align with the IOM report were also outlined in an article that I wrote with Jonathan Carmel, the attorney I work with at the New York State Health Department. And we basically have recommended for our state the need to strengthen clinician training, encourage public education, engagement, and empowerment in advanced care planning, and expanding the use of eMOLST. Our eMOLST system aligns with a recommendation in the IOM report that requires access to the presence of medical orders for the appropriate populations, and our eMOLST system was highlighted in the IOM report because of its unique approach to this issue. I want to go through some definitions on eMOLST. When we talk about forms, we're not only referring to the MOLST form, but also the chart documentation form that outlines the key elements of the clinical discussion process as well as the ethical framework. Users are individuals, clinicians with different clinical and administrative roles with regards to creating, updating, or accessing MOLST forms. Currently, under our statutes, physicians are the only group of clinicians that can sign a MOLST form, so they have the highest level of access in eMOLST. They can help create, update, and sign forms. Nurse practitioners, PAs, social workers, clergy who are involved in the discussion get access to creating and updating. We also have some clinicians, like nurses who are not involved in the conversation, EMS, that get access to read only. CMR, EHR are self-explanatory. Registry is an electronic database housing MOLST and eMOLST forms, as well as the chart documentation forms to allow 24/7 access in an emergency. And eMOLST is our state's registry, but in addition, it's an electronic system that guides clinicians and patients through a thoughtful discussion and the MOLST process that includes the ethical legal framework for making these very big decisions. eMOLST is programmed to make sure it's completed accurately, correctly, and ensures that it is accessible in an emergency. The system has been built to allow the clinician to print a copy of the eMOLST form on bright pink paper for the patient, as well as to have that available for those systems where they still are in a hybrid system and have part paper and part electronic system. It is the registry of forms, and it makes sure that the registry allows not only a copy of the MOLST form, but a copy of the discussion, what people want, why they want it, and it's available in an emergency. It is web-based, dependent on the Internet, and not any individual EMR. It's available statewide, and is accessed at nysemolstregistry.com. It contains the 8-step MOLST protocol, which is the communication process and the ethical legal framework. And if you notice, it's only step 7 where you complete and sign the MOLST, as well as our ethical framework, legal requirements, which can be complex, but it really represents patient protection to make sure that the orders are done correctly. And it produces, again, the pink MOLST form and a copy of the chart documentation form. Why eMOLST? Because our system improves quality patient safety, reduces harm, reduces the medical errors that occur when a paper MOLST says, I want to be resuscitated, but I never want to be placed on a ventilator, which is clearly a promise we can't keep, and it achieves the triple aim. We are aware of and basically share information on the POLST registry data as we educate our clinicians about eMOLST. And this is data that I know you're familiar with, so I'm just going to talk about it briefly. It was in JAGS in 2014. Oregon has had a registry for several years. They analyzed the first 2 years of their data, and they compared location of death that they had available from vital statistics with the treatment represented and requested by individuals. When patients had POLST forms in the registry and had requested comfort measures only 6.4% of people died in hospital. When they looked at the patients who did not have a POLST form, did not have a discussion, and did not have it in their registry, 34.2% of people died in the hospital. We have many videos to help illustrate eMOLST. This is a video from the attorney for my health department who makes the analogy of completing your taxes with pencil and paper, and none of us do that today. And he makes the comparison of eMOLST to TurboTax. We talk about accessibility and what happens in an emergency, recognizing the statewide nature, and if someone travels from Rochester to New York City, their eMOLST is in the system. In the event they forget their paper form on the refrigerator, what happens if they forget it on the refrigerator and don't have a MOLST in the eMOLST registry, recognizing it's available across care transitions. We also have videos that are basically illustrating feedback from our clinicians. This one is from a physician who has been using eMOLST for several years. In summary, it adds value, improves quality and legal outcomes, reduces survey deficiencies in nursing homes, provides a basis for a high level of accreditation for hospitals with JCAHO. Our providers are satisfied with the system and ensures accessibility and achieves the triple aim. I will share a case that we had in the North Country of an 82-year-old gentleman with chronic lung disease, congestive heart failure, recurrent episodes of respiratory exacerbations and hospitalizations. He had a healthcare proxy in a MOLST form. He presented to the emergency room with acute respiratory insufficiency. MOLST was left on the refrigerator. He was evaluated, treated, about to be intubated when the emergency room physician who had access to eMOLST found his form that was completed in the physician's office that said, do not resuscitate, do not intubate. Instead of intubating and transporting him 100 miles south, he was treated conservatively and discharged the day that we made a site visit. His wife said, thank you for MOLST, thank you for eMOLST. He died peacefully 2 months later. We have used this case to look at the cost avoidance analysis, and I've shared that also with our system. Bottom line is eMOLST improves quality, honors individual preferences, and reduces unwanted hospitalizations, ED use, service utilization, and expense, and aligns with the work that our systems are doing and aligns with the priorities that they have, including for Medicaid redesign, innovative payment models, et cetera. We'll now turn this over to Katie so that she will begin the eMOLST, and we're going to do this jointly as a presentation together.
Hi guys.
So Katie,
do you guys see my eMOLST screen? All right. So I'm logging into the eMOLST application. I'm selecting the location where I'm working. Many folks across our state work in multiple care settings that might not even be part of the same system. eMOLST allows access from all of them with one login. We also have single sign-on that allows access directly via EMR, and then deep single sign-on, as we call it, which can pass us patient context to allow one-click search. So when we land here, this is a list of my patients. In eMOLST, there are 3 ways to get patients on your list. The first way is to search for a patient by first name, last name, date of birth, and gender. The second way is to look them up by eMOLST number if you know it. Then the third way is to have a coworker assign patients to you. So we're going to do the first way, search for a patient by first name, last name, date of birth, and gender. I'm going to search for Bella Swan here. So the eMOLST application actually told us there are quite a few other Bella Swans that we've made in the history of doing these demos. But I'm going to say these results do not include my patient, so I want to create a new patient in the system. We enter some demographics about the patient here.
And if Katie's entering the demographics, I was just going to say it's really important to help us to differentiate the different individuals. And we've already seen folks with the same first name, last name, gender, date of birth in 2 nursing homes, one in Rochester and one in Albany. Sorry for interrupting, Katie.
No, that's fine. I was going to say we differentiate between Brooklyn and Buffalo. So on this screen, this is the patient summary screen. We just created this eMOLST number for Bella Swan. This is unique to her. This will always be her eMOLST number. We can edit these other demographic items, including her location if we need to. We can start a new eMOLST by clicking Create eMOLST here. We can also look at old forms in this drop-down. So this is the archive of forms that were signed. Obviously, Bella is a new patient to eMOLST. So she doesn't have any old forms, but we'll hopefully be able to show you something here later. If the patient dies, you can mark them as deceased. This removes them from your patient list. It makes them not appear in normal search results, but their data are always accessible in the registry on the back end. Administrators for the different clinical sites across New York State can retrieve their deceased patients' eMOLST forms whenever they need to. The list of custodians shows who has access to this patient right now. So a clinical team would see multiple team members here, and this occurs across HIPAA entities. So this means that if the Bella came from a nursing home, we could see nursing home folks' names here and where they're from. And certainly this helps from a care transition perspective, understanding who's been involved in this process. We can also remove Bella from our list. So say I'm no longer caring for Bella, I would remove her from my list. The eMOLST history table gives us like a brief audit log of what has happened to this patient and who has done it, certainly more information than we have in the paper world. So we're going to create Bella's eMOLST, and I want you to remember this screen because it's going to look totally different next time we're back on that patient summary. Okay, so here we get into the MOLST discussion. We have the opportunity to convert from a paper MOLST form. And say Bella had done her original DNR back in 2015. We can capture that date here. And this is approved by our health department so that we don't need to reobtain consent for patients who have already made these decisions.
Well, more importantly, in our state, and I would expect that it would apply in most states, once people have made a decision, it's not the authority of a healthcare agent or a surrogate to undo those decisions. So, and it's also part of how we change policies and procedures to make sure that people are using the proper language to be able to know that it's documenting decisions already made and not having to get new consent.
And we can go through this pathway. So we're going to convert Bella's. We can convert her paper form to eMOLST. We also have a tool to help us read paper forms if we need to. The patient status section, when we say the patient's not a child, it drives these questions to be disabled because we don't need to answer them. They're irrelevant. We answer some other basic questions that in our state affect notification requirements, other legal requirements down the line. Certainly who can make these decisions for people with developmental disabilities who lack capacity. When all three of these are no, it affects, we won't see future questions later. We're just going to do a simple case of a patient making their own decisions. Does that sound good, Dr. Bomba?
One of the other important parts that happens with our system is it disables it. So it'll really move the clinician through this process to be able to do it. And that's really the coding that's involved behind the scenes to really drive the correct process. As we looked at health status, we initially had the palliative performance scale that many of you who are involved in palliative care may be familiar with. We found that did not help us to differentiate the types of patients that are appropriate for MOLST or for a POLST paradigm program. We began to use the clinical frailty scale, got permission to use that. It's been well tested in Canada, and it has both images and a description that we have found that our clinicians have been able to use, without regard to the kind of clinician status. So all of our clinicians find that it's really easy to be able to use. And this is for adults. When it's a child, we work with pediatric palliative care physicians to look for the next scale that Katie will demonstrate and show down as she moves down on the screen. The key is this is not a child, so in the child it's disabled, so the clinician doesn't even have to worry about it. The important piece that we do is align with what we teach about the MOLST program with how we talk about frailty, how we talk about prognosis. We also put into this pathway for discussion looking to see if people have advanced directives and the type that they have, because it aligns with the ethical framework and legal requirements. And if people have not done advanced care planning before, we really drive the question as to do they have the capacity to choose a healthcare agent and participate in doing that. If it's a durable power of attorney for healthcare in your state, it's the same concept, just so that we assure that as they move forward, we have the right decision maker. And so we also assess capacity for the person to be able to make decisions. And as Katie's demoing, if the patient is making their own decisions, we then get into what all of us in our POLST paradigm program talk about is let's find out what the personal values and beliefs are. And we have a list that came early on from the early use of eMOLST that are checkboxes, but it's not comprehensive. And so we are able to then go into an actual text box and document specifically what comes out of the conversation. We use the geriatric literature to look at goals for care discussions prior to MOLST completion. And in the geriatric literature, we know that people focus first on longevity and goals that relate to that. I want to attend my son's bar mitzvah, my granddaughter's wedding, and then they will move to functional preservation. I want to age in place. I want to do as much as I can. And we have put into the application some examples that people can align with. And then finally, we know that people move to comfort care and quality. The more that is in this text box, and as we train, we suggest that people use this to document the conversation. And the video that I mentioned earlier, Dr. Patrone uses it as a diary. And in doing so, she has always at her fingertips exactly why people have made decisions, when they have done so, and even when people have chosen not to go back to hospital and they're staying at the nursing home, she's able to, over time, go back to look at what the goals for care and what the content of the discussion was. And that's been extremely helpful in terms of helping people to not try to overdo decisions, even to suggest that, because people can go back and say, remember when mom said this, remember when we had this conversation. The system automatically drives to the right checklist, and this is important for our clinicians who are busy and want to do a good job. It takes them right to what the ethical legal framework is for making decisions. and we save and continue before we move on. In looking at this for a team-based approach, we can also scroll back and also affirm the discussion. We can make sure before we move on to the medical orders, let me make sure that I understood all of what we said. And that's true whether it starts with the nurse practitioner starting it, if the physician is reviewing it, and eMOLST can affirm that discussion, and nothing is set in stone until the physician signs the orders. As we all know, families or individual patients may think of additional information, and so all of the content can be edited in eMOLST, and again, it's not firmly established until the physician signs. So Katie will demonstrate how we can't have incompatible orders in the eMOLST system, and I think she was also pointing out that we have a lot of embedded videos that we've put in to have real-time education. If we have a social worker or a nurse or nurse practitioner talking about the poor survival rates after DNR, we have a short, less than a minute clip with 3 physicians talking about what CPR really means and how people who are appropriate for MOLST don't have good survival rates. So Katie will say that this individual says CPR and then move on to the next part that demonstrates we can't say do not intubate, and the system has disabled that.
I think it's also important to remind folks here, because they're coming from across the country, that this is specific to New York's MOLST form, but all of this is customizable to any state's form, and the language that they use on their form, the specificity of that, as well as the legal requirements you see here are certainly specific to New York.
But the legal requirements do align, as I said earlier, with the ethical framework. So if you're looking for do not intubate, it would be rolled up into limited intervention on many of your forms. So we're going to go back, and Katie's going to demonstrate just completion of the MOLST orders in the way we do it in New York State, but also look in terms of how we talk about and where we document trial periods. I think what's important is we want to be able to get through this demo, but also show some of the workflow and the team-based approach, and then have enough time for questions. On our form, and it may not be in all of your forms, but we also document when a person wants a trial, what does that exactly mean? Because it really is helpful information to the next clinician caring for that individual as they move across a care transition, particularly if the patient has lost the capacity to share what does that mean. And there's a lot of variability, clearly, for a trial based on the person's clinical status. Before one goes on to consent, again, one can scroll up on the screen in eMOLST to be able to affirm that the orders were appropriate. Katie is moving into the consent. I think many of you know that New York's form is different, and our consent is divided on page 1 and page 2. We went quickly through the screen that showed page 2, and it was designed that way because of our laws, but also in eMOLST, what we didn't show is the ability to skip and return later, which is helpful to the nursing homes who need to really ask on day 1 about resuscitation preferences. We also have the ability to basically say the decision was deferred in any one section, recognizing that every person is in a different stage of their ability to make decisions on MOLST or on a POLST paradigm form.
So I deferred the IV fluids decision so they can see what it looks like.
Nice, I saw that. So we'll be able to show you what the form looks like and how you can easily go in and go back and make that decision and have that conversation. So consent is done, and you'll see simply the chart documentation form is fairly simple. The requirements when one has capacity is that there is informed consent and that there are witness requirements. In the eMOLST system, it's always verbal consent with 2 witnesses. The physician can be one of the witnesses. And in our system, oftentimes when people are working in a team-based approach, one is really having a serious conversation, the other is serving as a scribe. And as you can see at the end, something that we put in initially, which was optional, as many of you know, Excellus had a reimbursement model before the new CPT codes, and it allowed our clinicians, physicians, nurse practitioners, physicians, nurse practitioners, PAs, who were trained to be able to document the time spent. And many of the clinicians now are using the new CPT codes and using this feature to be able to document time spent. Everything up to the signature can be done in a team-based approach. We work with our systems who are using eMOLST for them to basically identify the level of access that I mentioned earlier that individual clinicians get. In our state currently, unless public health law changes, only the physician can get access to signing the form. They get access in a way that they get special questions, special images, similar to electronic banking, and we educate our physicians not to share passwords, as they wouldn't share passwords or any of these questions with anyone for their banking, their personal banking. So Katie has just brought up the eMOLST form that we've created in the system. You can see the auto-generated eMOLST number and all of the information that was procured during the conversation and during looking at the eMOLST form, in addition to the fact that a decision on IV fluids was deferred. You can see the date and time for creation of the eMOLST form in our training system. And as she scrolls through, you'll see that we have a section, as you know, on review and renewal to be able to document when there are times where there's a change in health status and when people make changes to their MOLST orders. And as she scrolls through, she'll also show you the MOLST chart documentation form that aligns with the checklist that we created for our state that was actually created by our health department to help people to align with the right process to use, both clinically as well as the ethical legal framework. Katie has stopped here to show the goals for care discussion, and this section can be as long as the individual clinician has basically done the discussion, and we encourage people to document it. Katie's also shown you what her signature looks like. She's going to go back and update and show you how easy it is to update that one area that wasn't talked about. But before she goes there, Katie, why don't you talk about the summary of orders sheet and how it changed from when you first demonstrated?
Yeah, so now the patient summary screen, this didn't used to be here because there were no orders that were signed. So in eMOLST, you may have a draft form that was completed by a nurse practitioner or a nurse and a social worker together in the nursing home, for example, where they're waiting for the physician to confirm the discussion and sign the orders. Once the orders are signed, this is what you see. The actual orders themselves, the PDF is downloadable to see the full form. It tells you who signed it and when. And we're going to hit review and renew. This button didn't exist earlier because there was nothing to change, right? We had to start from scratch. Now we can begin with the most recent orders and make a small change, for example, to the IV fluids decision. So all this stuff stays the same. Everything is saved for us. We're going to say no IV fluids.
Yeah, and in this setting, there may be some pertinent discussion that can be added about IV fluids. For the sake of the demo, we're not demonstrating that. We want to be able to show you how quickly you can make an edit to any section of the eMOLST form without having to start from scratch in the paper world. What's important is that the first discussion is done and then the orders are obtained. And it also allows for retention of the consent for resuscitation. Go ahead, Katie.
That's what I was going to say. So we retained that original resuscitation consent, and you're going to actually see the original date and time for the consent were retained. And here, Bella made a new decision, so we have to document who was part of that decision.
And the witnesses may be different, and that's why in eMOLST it clears it out for the second time in the second page.
And now we can move on to the signature section. So if I was the nurse practitioner or the social worker, again, I could have made those edits, or the nurse, right? I could make those edits with the patient and family and then refer it to the physician to confirm it with the patient and family and sign it. We also have workflow features embedded in the eMOLST application that allows people to easily share these patients in a team-based way. So here's the new form. Sorry, Dr. Bomba.
Yeah, I was just going to say in our state, it's not merely the physician signing orders. It's really about affirming the discussion from a team-based approach and making sure that those are appropriate and then having the physician sign the orders. But the documentation of that discussion is always done in the system.
So here, the original date and date and time for the resuscitation is documented. This is the time when the physician signed originally. And then here is when we made the change to the IV fluids decision. And you can see how the date is the same, of course, but the time is different. And we added some more instructions here, so the font got like a little smaller for us to fit more information. And here's our first documented review and renew. It says who did it and when. Where were they? And our documentation is still attached. Anything we changed in the documentation would be captured. We also, I don't think we mentioned this, but we captured that original consent if this came from a paper form right here, so that there was never a question if Bella had lost capacity, that they could always go back to that original and know when she originally made this choice. And I'm going to be able to show you guys the voided form. This is the old form that we did prior to review and renew earlier today. And this was where we had the IV fluids decision deferred. So now this order is void in favor of the current PDF.
So in the paper world, we teach the clinicians, and it's part of the instructions that are from our DOH, that we should have that large void. And we just talked about that in a MOLST training down on Long Island today. And that's really what helps to differentiate those forms when you have two different kinds of forms. In our system, the only correct form will be generated by the system in an emergency when there's access. So you can see what Katie's demonstrated in terms of the voided forms in the registry versus what would be generated as the latest set of orders. So you always get the correct set of orders.
Right, while retaining the others for your medical record, basically. Okay. So does anybody have any questions at this point? Because I can show the workflow and stuff like that.
Katie, can you just scroll down before Hannah sees if there's questions and we open it up, and before we do workflow? Because as you look here, you'll see the eMOLST history, and everything that's been done on this individual form will be documented. There's a lot more complexity in the back end of the system, but here's where if you use a team-based approach, you would know who's involved with the discussion, and it's all documented. It's much more difficult to try to access that kind of information out of a clinical record unless it's been really designed specifically to capture all of this. This really tells who's been part of the discussion, who's been doing some of the editing, when was the physician involved in signing the form, when was it updated, and we have a long-running individual history on that individual patient. And it really outlines, again, when it was accessed. And we didn't talk initially because we will show in the workflow, but there are attestation statements in the system to make sure that we comply with HIPAA and all of the privacy and security concerns. And what we're showing you today is not the actual site. We didn't mention that at the beginning, but this is the training site that we use to train others, and I think Katie alluded to it, but just for people to know there are no HIPAA violations. You're not actually seeing our actual registry. You're seeing our training site. So before we do workflow, Hannah, are there any questions?
Yeah, we do have two questions. One was from a little bit earlier. It asked, what is the triple aim?
What is the triple aim? It is to really improve the health of the person, improve the quality, and to reduce costs. So it's better care and better quality and reduce costs. Second question?
Okay, great. Second question, how many hospitals, clinics, nursing homes, home health agencies, and hospices are using eMOLST?
Wow.
Changes,
So
it
sounds
changes
like
pretty much every day, so it's really tough to know it. And I think probably the important part of the history of it is we started in one region in Rochester, and we had hoped to build a model in one part of the state and really involve our RIO, which is a Regional Health Information Organization. And instead of working just alone there, we had such an outcry from other parts of the state. We have made it available, and we're working statewide on it. And truly, it varies each day. And what I would say is what we try to do is look at a community approach. And so as we look at it, we're not trying to do an individual facility alone, though that's how it starts in the community. But as we're working with communities, we talk about making sure that a hospital is beginning to get access, for instance, in the emergency room. Though we have found, you have to start somewhere. So we started first with a large nursing home on 2 campuses where Dr. Patron is that I mentioned earlier. And they had just paper records. The hospital wasn't using it, and they saw a lot of value to it. Our ultimate goal is to have all of our systems using it and having a single registry for the state similar to our organ donor registry, similar to our immunization registry, and to have it connected with our health information system. The approach we're taking is not so dependent on what are the number of hospitals and nursing homes, but how are we building the system to accommodate a system of care and how many clinicians we're enrolling. So while we have one hospital where we've enrolled thousands of individuals, in another hospital we've started with a palliative care team. So there's a lot of variation in terms of how people are actually doing end-of-life conversations and how they want to start it. So just counting hospitals and nursing homes is not enough. We've also really begun to expand upstream with a lot of engagement of physicians who are working on patient-centered medical homes and those who have done already patient-centered medical home certification are moving on to practice transformation. And so many of those are moving upstream. Rather than looking
Dr.
at...
Bomba,
yeah, go ahead, Katie.
The NCQA designation, eMOLST meets some of those requirements for them.
I was going to mention that next. So we had a physician who was trying to use eMOLST for NCQA and was told that couldn't be done. I did get a notification, or I did do an outreach to NCQA, and they have affirmed that eMOLST would qualify for both either quality for one of the preventive measures or for one of the reducing basically cost measures, so a cost utilization measure. So they can use it for either preventive measure, cost utilization, but not for both. So we will be spreading the word among our both offices who are working on PCMH and or practice transformation. And for those of you who are working on POLST paradigm programs and are looking at your POLST programs being eligible for that, just connect offline after the webinar, and we can talk about that or share information. Any other questions while we've been talking, Hannah?
Yeah, we are getting a handful of good questions. Let's see the next one. How is this rolled out and communicated to the healthcare community?
We do it in multiple ways. Katie, do you want to take a start, and then I'll talk?
Sure. Yeah. So I think that there are practical ways that hospital systems have informed. For example, recently we had a hospital system in the Hudson Valley select eMOLST as the exclusive tool for documenting any order to withhold and withdraw life-sustaining treatment. They communicated this at first to their employed physicians and then took that extra step to reach out to everybody who admits to that hospital, who has privileges at that hospital. They reached out to a number of medical practices in the area and said, this is our expectation now, which actually has been really helpful in that region of the state in terms of getting those other upstream folks as well as downstream folks like nursing homes in some respects on board with the eMOLST application in terms of utilization. I think that, I mean, we're a small team, so it's me, it's Dr. Bomba. We have a coordinator in our department, Meg, and we have a summer college intern who's wonderful. But it's just us, and so a lot of it has been word of mouth. We've done presentations in terms of the availability of eMOLST, through our hospital association across New York State, the
so Katie, can I just
variety of nursing home associations. Yeah.
Katie, can I just pick it up from there, because I think you gave a great anecdotal example, but I think on a very higher level, we have a MOLST statewide implementation team, and we have representatives from Haney's, from IPRO, from multiple nursing home associations, from our state medical association, as well as the New York American College of Physicians, et cetera. And so what we have been doing to be able to spread the word since we started and since we've moved forward is through our team and through dissemination through the usual channels of communication to make people aware of it, as well as doing hosted webinars to be able to share that. And as an example, in working with New York American College of Physicians, we've done it in multiple ways. We've done sessions with the hospitalist group. We've done it for the general information for the membership. For MISNI, we did one. I did one earlier this month for general MISNI membership. As part of that communication process for all of our physicians, I'm doing a series of articles for MISNI. We've done a lot in the past about eMOLST and MOLST, but this is a series that we're doing, and we're looking at the same type of series of webinars that we started doing with NYACP. In the articles in the electronic newsletter that's published monthly, the first one was how has end-of-life care changed in the United States, and really focused on the new codes. The next one is on eMOLST. The next one will be on clinician tools. So we do a lot with our partners. A great example is IPRO. IPRO is our quality organization, and we're working with IPRO on those three prongs that I talked about earlier: clinician training, public engagement, and eMOLST implementation. And we have a special innovations project from CMS that we're doing in both counties on Long Island. And Katie and I are in both two places today, and I'm on Long Island with IPRO doing education and engaging people on eMOLST implementation. So we have a multi-pronged communication and marketing approach to helping our hospitals, nursing homes, all clinical sites, and our physicians and other clinicians know about eMOLST. And Katie gave a great example in Orange County where one passionate palliative care physician has moved the entire county to be able to use eMOLST, and now it's the sole documentation tool for end-of-life decisions in the hospital, as Katie said. Other questions?
Sure. Another question. I work as a physician in New Hampshire. Would I have access to an eMOLST if someone from New York was visiting in New Hampshire and I needed to access it?
So I think at this point we're building it for the state, and we're building it also providing access initially for physicians in our border states, because we have already started where we see that. If the physician in New Hampshire wanted to have access, we would need to grant access. If you think about this, this is currently a registry for the state of New York. So we have not basically done outreach to look at physicians in other states to give access. So we expect that we will do that, but starting with our border states, because our border states in particular can be caring for New York State citizens, and their physician may be in one of our border states. And so we're beginning to have those connections, particularly along the border, the southern border with Pennsylvania, and we see a lot of potential in the tri-state area and downstate, and as we begin to look in the North Country with Vermont. So the possibility is there. We have not gone out to other states to provide access at this point in time. Other questions, Hannah?
Yeah, absolutely. If a physician has access to eMOLST, can they see the form for a patient not in their list using the search function?
Yeah.
Absolutely.
So in eMOLST, they can search all of New York State with that search function. They actually are searching all of New York State. They don't have to specify where they want to search. It is automatically everywhere. And that differentiates us from other registries, nationally, where some registries are accessible, via another mechanism. Here it's directly accessible to providers at every level of care.
And I think that was what I was referring.
Anybody can be qualified.
I was also referring to that earlier, where that would be when you search for it. Katie searched and showed you creating. We also have put in place the attestation statement so that people are not just fishing within the registry and looking for family members, et cetera. There's an attestation statement to say, I'm searching the entire state of New York because I am caring for this individual person. And then you say, yes, I'm caring for this person, and you have immediate access and can add them to your list.
So
other
we could
questions?
search,
Yeah, we can demonstrate that while we see if there are other questions. You want to demonstrate that? Okay.
Yeah, I'm going to demo it. I had to take a patient off my list so I could search for them to demo the search function. I'm going to search for Jack Sparrow. Maybe I'm seeing him for the first time. Okay, and so we got, I mistyped. I said 1908, but it actually is 1918. There's the attestation for HIPAA saying, yeah, I'm currently treating him or coordinating care for him, so I get to see his information. Here's where the last person left off, actually, which is this person, and it shows us, right? The form was created, and then a while later it ended up being voided, but we could start a new eMOLST for Jack, and we can see what those old forms looked like if we wanted to.
Okay, next question, Hannah.
Great. Yes. Since the focus is on improving the system to accommodate clinicians that begin using it for advanced care planning, how has the eMOLST improved for expanding the system of care for advanced care planning?
So again, that's why I demonstrated a little earlier, advanced care planning as being an entire process, and the MOLST or POLST cohort is really for the sickest in our population. And so we have been focused on building and securing funds, additional funds for back-end analytics that would help us to address exactly the question, both from a perspective in terms of ensuring that people are dying where they want to die, and analyzing if they haven't, was that appropriate, as was demonstrated in the study with the POLST Oregon Registry, but also at some point being able to do more advanced research with, obviously, IRB approval as we have a larger database. Because in order to be able to appropriately search for persons, we're also looking at appropriate demographics and looking at cultures. We also see that in the future we'll be able to look and see about how people's values, beliefs, and goals for care translate into their choices, as well as how choices change over the course of time as goals change, and how they might change over the course of a movement from one care setting to the other across care transitions. So we're building it for the clinical use, but also for the future research. And we have not focused on the research at this point in time. Other questions, Anna?
Another question. What is the cost of the eMOLST system? Is it off the shelf or developed specifically for New York?
Yeah, so we have not charged our systems for access to eMOLST, and it's been supported wholly by Excel Blue Cross Blue Shield, not only for our team, but also the disaster recovery plan with our IT system, and we'd be happy to basically work with any system to look at how we could modify that for any individual state. It's not a specific number that we would quote because every system is a bit different. But the infrastructure and the way we presented it in terms of the discussion, the ethical framework is the same. We would have to tweak it to be able to accommodate any form differences, but would not have any difficulty in doing that or having to create a documentation form that aligns with legal requirements in any state.
Great. I do have one more question for you. For people who are interested in learning more about the development of the registry, are you able to share things such as time, cost, and legislative barriers?
So one of the things that we're working on, I'll start with the last one, which is the legislation. We created our eMOLST system through a grant in our state. Initially, it was a small startup grant. The rest of the support has come from Excellus, as I mentioned earlier, and because we had significant legislative changes with our surrogacy laws in 2010, we really started over. Currently, we see that one of the important things that we want to be able to do is to have mandatory submission. So we have an eMOLST registry bill that has been introduced in our Senate during this session, and the concomitant bill will be introduced in the Assembly to, one, put the term MOLST into legislation, two, establish the registry, which is there, and begin mandatory submission. We don't have a start date immediate for mandatory submission. We would be looking to next year because we've been seeking funding for that. In our legislation, if you attach funding, it's unlikely to get passed. And so we're actively involved in the legislative piece right now. What it costs is really a hard question. Happy to talk offline because it's been really over many years that we've been working on this. And the cost, as you look at it, is the cost of not only the development, but the cost that we have incurred as the small team that Katie described, as well as the cost of our IT staff and some of what we've used in terms of our internal resources to help us with all elements of the implementation and the collaboration that we've had with folks like iPro, like our state associations to help move it forward, and working with the individual hospital systems. And there are some other costs in terms of moving from paper to eMOLST that Katie alluded to, that we have some technology that will help us with that as we move forward with our mandatory submission. I see we're at the top of the hour. Any last-minute questions, Hannah?
I don't have any more for you. We can definitely follow up more through email, and the recording will also be available. Do you have any other concluding remarks?
I think one of the things that I would say is that for those that have had a taste and interest in our eMOLST application, we really only demonstrated today the creation of the forum and have not had a chance. And I think it was important to stop and address questions. What we didn't get to is some of the workflow and some of the back end. And so if there is interest, and as you complete the evaluation in terms of looking at some of the other components, particularly the workflow, because all of us are working on a team-based approach, we'd be happy to demonstrate that at a future webinar for you. Katie, do you have anything else to add?
No, I'm good. It was a real pleasure getting to show eMOLST to you guys.
And thanks, Hannah, to you and Amy.
Oh, absolutely. Yes, it was a pleasure to have you guys present today. Thank you so much, and thank you for everyone who listened in.